Hello, good morning everyone, and this is your VTuber pharmacist, Ethan, and we'll be covering our introduction to biopharmaceutics and pharmacokinetics. So in the previous video, we have already discussed what would be the coverage of this course, and let's get started with biopharmaceutics and pharmacokinetics, and this will serve as our first lecture. So first, what is this course? So this course is divided into two major divisions, which is our biopharmaceutics and our pharmacokinetics. Both of these subjects relate to how the drug is being treated by the body. Namely, for biopharmaceutics, we take into consideration the physicochemical properties of our drug and how it affects the body. And then for our pharmacokinetics, we deal with the measurement of drug availability in the body and how fast or how slow the drug is being processed by the body. So biopharmaceutics studies the factors of pharmaceutics in relation to its effect on the body, namely absorption, distribution, metabolism, and excretion. We study how different changes applied to our dosage form can affect its performance inside the body in terms of our ADME. So biopharmaceutics encompasses various aspects, including drug formulation, drug delivery system, pharmacokinetics, and pharmacodynamics. And it is very much deeply involved with drug solubility, permeability, stability, bioavailability, and bioequivalence. All of this we will be discussing in our finals grading period. So biopharmaceutics, it is important for our pharmacy profession because we rely on the study of biopharmaceutics for drug design and drug development. We rely on the data we obtain from our formulation studies and our clinical trials to make the best possible dosage form that would be safe and effective. And in essence, biopharmaceutics is centered in making a drug effective in a biologic medium. So in summary, we design a drug, and with the help of biopharmaceutics, we ensure that it works inside the human body. Next, we have our pharmacology. You are already familiar with pharmacology. So pharmacology is the branch of medicine and biology concerned with the study of drug action. So it relates how the drug and the organism interact, how a chemical can affect the normal or abnormal functions of an organism. We have two broad categories for our pharmacology. We divide it into pharmacokinetics and pharmacodynamics. Pharmacodynamics, you have already tackled this in your pharmacology 1. You have discussed how drugs work, what's their mechanism of actions, how they are exhibiting their effects or their adverse effects. Pharmacokinetics, on the other hand, I will be discussing later. It's the other half of the main division of pharmacology. Other examples of pharmacology are your toxicology, your toxicokinetics, toxicodynamics, pharmacogenetics, and pharmacoepidemiology. In terms of pharmacodynamics, it is broadly defined as the biochemical and physiological study of drug effects. What you study in pharmacodynamics is how a drug can change natural processes inside your body. So in essence, or the summary is, it studies what the drug does to the body, how the drug works, how the drug interferes or changes normal or abnormal function. This is all under pharmacodynamics. So if you think of pharmacology 1 and pharmacology 2, that's pharmacodynamics. Pharmacokinetics, on the other hand, is the second part of our course. When we say pharmacokinetics, it is a field of pharmacology dedicated to determining the fate of substances. What we study in pharmacokinetics is how the drug is affected by the body. So what happens, how the drug is absorbed, how it is metabolized, how it is distributed, excreted, etc. It entails the story from ingestion to excretion of the drug. We're not dealing with the drug's effect on the body, but more so we're talking about how the body can change the drug. So it primarily deals with our Ladmer processes, or what the body does to the drug. So that's the main differentiating. So pharmacokinetics, what the body does to the drug. For our pharmacodynamics, what the drug does to the body. So here are our Ladmer processes. You have your liberation, which will encompass your dissolution and disintegration. Next, you have your absorption, distribution, metabolism, excretion, and response. Please do take note that these processes need not be in order. Sometimes drugs can be metabolized before it is distributed, or it need not finish one step at a time before it moves on to the other step. Most of the time, all these processes happen all at once. And in pharmacokinetics, we try to figure out what's happening at the current moment in terms of drug dosing. Next, we have our clinical pharmacokinetics. Clinical pharmacokinetics is the application of pharmacokinetic methods. So this applies the knowledge of computation of your drug predictions, and it is applied in TDM, or our therapeutic drug monitoring. So therapeutic drug monitoring is a process in which we regulate the plasma concentrations of drugs which has a narrow therapeutic range. So these are drugs that could be effective and toxic based on very slight changes on plasma concentrations. So these are considered narrow therapeutic range. So what do we mean by therapeutic range? So next we have our therapeutic range, or our therapeutic window. So when we say therapeutic range, it is the concentration range of a drug between the MEC and the MTC. These are similar sounding terms, so you should clarify each in your head. When we say MEC, it's called your minimum effective concentration, based from the word itself, effectivity. So when we have a plasma level versus time curve like this, the minimum effective concentration is usually the first bar you will see. This is your MEC. Like for example, this is 1 milligram per ml. So any concentration above the MEC, this is effective. As long as the concentration is above your MEC, the drug is expected to work. Now, the higher the MEC, the more drug you need. The lower the MEC, the less drug you need. So more potent drugs tend to have a lower MEC. The second value is your minimum toxic concentration, or your MTC. Usually it's the second bar in your plasma level versus time curve. It's similar to the MTC, in which any value above this point would exhibit toxic effects. So the minimum toxic concentration is the level in which we are expecting toxic or adverse effects to occur. So take for example aspirin. If you go above the MTC, we are expecting tinnitus or bleeding disorders. Okay? Please take note that a drug can be toxic and effective at the same time, since the only definition for MEC is that the concentration is above it. Even toxic concentrations are considered effective since it is above your MEC. Now, when we say therapeutic window, it is the gap between the MEC and the MTC. So this is your MTC again, and this is your MEC. This is your therapeutic window. This is what we are aiming for because it is effective since it's above the minimum effective concentration and it is below your minimum toxic concentration. It's effective and it's not toxic. So it fits the description of our drug, safe and effective. Now, the wider the difference between your MEC and the MTC is, the safer it is. Because you have a wide range of concentrations that are safe, and effective. When we say narrow therapeutic range, it means that there is a large tendency for a drug to become toxic. The concentration between effectivity and toxicity is very short, or they are near to each other, in which without proper dosing, toxicity will occur. So some drugs which have a small therapeutic window is your warfarin, digoxin, phenytoin, and tacrolimus. Next, you have your drug exposure. When we say drug exposure, it's a general term to denote any measurements of your of your drug in your blood or in plasma. When we say drug response, it refers to the direct measure of pharmacologic effect of a drug. It could be endpoints or biomarkers. So when we say drug response, this is the expected physiologic outcome when we give a drug. Take for example, you give a drug which is an antipyretic. Take for example, paracetamol. Our expected drug response is that the fever would go down. Or if you give a anti-cholesterol drug like simvastatin, our expectation is when we measure the plasma or the blood, there should be decreased lipid levels. So those are our endpoints or biomarkers. Now this on the screen is your plasma level versus time curve. You will encounter this very often, as I will always be drawing samples of this to prove or to show illustrations of what is occurring in the body. So usually on the left, you would see your plasma concentration. On the bottom, you would see time. It means that it tracks the concentration as time progresses. It both starts at 0, meaning the moment of administration, and it tracks every time you measure the concentration of a drug. Okay, now here on the screen is a lot of information. Let's tackle them one by one. First is you have two dotted lines here and here. So this is actually your MTC and your MEC. It shows the minimum effective concentration and your minimum toxic concentration. Anything above the desired response line or your MEC, the drug would show effectiveness. Anything above the adverse response or the MTC levels, you would experience now side effects or adverse effects. And the space between the adverse effects and the desired response, this is your therapeutic window. Okay, we have already talked about this earlier. Now, let's have different parts. Next, you have your peak of effect. The peak of effect, this is your Cmax. It is the maximum concentration that your drug was able to reach after administration. So it's simply put, it's the highest concentration your drug was able to reach. Next is the duration of action. The duration of action is a measurement of time. How long was the drug effective? So to know the duration of action, you need to see at what time the concentration was able to surpass the MEC and what time the drug exited the MTC. So in this period right here, the drug was considered effective because the plasma level concentrations were above the MEC. Okay? So another thing is any concentration below the MEC is considered subtherapeutic. So we don't expect any pharmacologic effect if the drug is below the MEC. Okay? Next, we have our toxicokinetics. When we say toxicokinetics, it is the application of pharmacokinetic principles to the design and conduct and interpretation of drug safety and evaluation studies. We usually use our toxicokinetics in our earlier phases of our clinical trials so that we could establish a safe dosing regimen for our animals and our humans. So in terms of toxicokinetics, the data we obtain from toxicokinetics aids in the interpretation of toxicologic findings in animals and extrapolation of the data to humans. So if we were able to establish a safe dosing for animals, we could use that data so we could start testing on humans safely. So toxicokinetics are performed in animals during preclinical drug development. We don't test toxicity on humans, ideally. So other things to consider is data from our clinical trials. So these are just some terms you should be familiar with. When we say ED50 or effective dose 50, this is a statistical value in which it is the dose that produces the response in 50% of the population. So take for example, you give 70 milligrams of a drug for 100 people. If 70 milligrams were able to produce an effect on 50% or 50 persons, that is the effective dose 50. So the dose of the medication that produces a desired pharmacologic effect in 50% of the studied patient populations that take the medication. This is obtained from clinical trials. Next, you have your toxic dose 50. It is the dose in which 50% of subjects experience toxicity. It's similar to your effective dose 50, but this time, instead of assessing effectivity, we're checking toxicity. And finally, we have our lethal dose 50. Lethal dose 50, we don't test lethal dose 50 on humans. As much as possible, we would like to keep our humans alive. So LD50 is your lethal dose 50. It's a measurement of the amount of drug that produces death in 50% of the test animals. So it's one of the toxicokinetic values we use to measure short-term toxicity of a material. So if the lethal dose 50 is very small, it means it's a very powerful poison because it could produce death in low amounts. Okay, and that concludes our first lecture, which covers our introduction to biopharmaceutics and pharmacokinetics. Main takeaways from our lecture is what is biopharmaceutics. It's the study on how physicochemical properties can affect the drug's performance inside the body. When we say pharmacokinetics, it's the study of how the body affects the drug from absorption, distribution, metabolism, and excretion. We talked about our plasma level versus time curve, what is MEC, what is MTC, and we also discussed some statistics-based terms in terms of dosing effectivity and lethality. So our next lecture we would be talking about now is our models and drug sampling. Okay, that will be all for this video. Hope to see you on the next one. Thank you for listening.